Welcome to this lecture, Theorizing Knowledge and Gender in mHealth. This is part 2, Translating Knowledge for Improved Health. In Information Communication Technologies, or ICTs, much of the theorizing around knowledge is captured in ideas about the digital divide. This is the recognition that some people and countries have access to the technology that makes it possible for them to receive and use knowledge in particular ways, but others do not. In relation to development, the digital divide was initially conceptualized in terms of access and the need to help populations in poor and rural areas to gain access to ICTs. Emphasis was put on two things: to have access to connectivity and tools, and to have access to content and information conveyed by these tools. This was seen as the first and second order digital divide. The first order digital divide was connectivity to ICTs. The second order digital divide, the ability to use and contribute to content available on ICTs. Approaches tended to focus on technical solutions, but as this lecture will show, there are a host of other issues, including regulatory and policy problems. In thinking about the digital divide, we need to be aware that technology also has political values and qualities built into it. It is not politically or value neutral, even though it is often portrayed to be this. Rather, technology is the product of particular relationships and interactions between machines, between the inventors, the designers, and the end users. And the values that dominated when technology was being produced also influence the usage of that technology. In the case of ICTs, it's worth remembering that the origins are military and industrialists and engineers, all of which tend to be predominantly masculine. To what extent have these initial conditions of creation influenced the ways in which ICTs are used? Kofi Annan, in 2003, recognized that the digital divide involved a technological divide, namely the widespread lack of infrastructure in many parts of the world, a content divide, namely an emphasis on English and a crowding out of local voices and views, and a gender divide. The digital divide thus refers to exclusions along lines of race, class, education, and geography, which affect less privileged men and women all over the world. Gurumurthy argues that this initial exclusion of women and of development values has been perpetuated in ICTs. Women still have few opportunities for ownership or influence. Corporate monopolies and national interests continue to dominate, and as a result, surveillance and sexism are emphasized over democratic substance and equality. Turning now specifically to mHealth and gender. Empirical evidence demonstrates that around the world, women's use of ICTs is less than that of men. We know that women's exclusion from ICT access and use is informed by a range of factors, including social relationships, acceptable gender roles, geographic location, language, mobility, education, and class. In relation to mobile phones, Tenhunen argues that women in West Bengal, India, might use their mobile phones differently to men. Men tend to use phones in ways that connect them to the public sphere. Women, however, use mobile phones to reaffirm private and domestic connections. As Tenhunen documents, women phone their relatives to talk and to find out how family members are. In particular, they connect up with their brothers and fathers. Men, however, use their phones to communicate with their friends rather than their relatives. In these conversations, men talk about work and travel. Other research in India points out that 42% of women targeted by an mHealth intervention had to rely on their husbands due to the device or textual literacy barriers. The cost of owning a phone or making phone calls is another much recognized dimension of the digital divide. For women, this is frequently reinforced by their dependence on men, both for finances and to undertake the financial transactions associated with mobile phone use. Hafkin and Taggart point out that, in general, there are far greater demands on women's time, the triple burden of housework, childcare, and income generation, and this radically reduces women's opportunities to invest time in learning about, accessing, and using ICTs. Constraints on women's time also influences their ability to travel to and from public ICT facilities. There are other categories along the lines of age or caste or education or rural-urban locality which also reflect exclusions and the digital divide. Yet, as Deshmukh and Mikkel show, women are incredibly interested in learning about health and in using mobile phones to do this. Bo Nielsen and Veldrop argue, similarly, that ICTs have a dual promise. They facilitate increasing commercialization and privatization, with the general exclusion of women and social development values. Simultaneously, however, they offer great promise to subvert these same hierarchies and exclusions. This Janus-faced characteristic of upholding power relations and simultaneously subverting them makes ICT technology and mobile phones incredibly attractive tools. ICT technologies have been extensively used in health information dissemination, with creative use being made of television and radio. Examples abound of soap operas on television and radio to address women's sexual and reproductive health, of videos showing women how to respond to commonly experienced health problems, such as using oral rehydration therapy to treat diarrhea. ICTs are also being used to enhance public health service delivery, both in terms of using mobile phones to facilitate closer communication and interaction between different members of the health system and between individuals, and to provide large-scale, regular and targeted dissemination of health information messages. ICTs also offer new ways of collecting and analyzing data about ill health and can inform disease-specific interventions. Most recently, there has been a host of new possibilities and innovations using algorithms and other technology to assist in rapid diagnosis. In these examples, knowledge is embedded in the algorithms. This suggests that within mHealth, there are different kinds of knowledges and they are being conveyed in different ways. I want to turn now to look at some specific examples of mHealth. One very well-known example is the Mama Initiative, or Mobile Alliance for Maternal Action, which has been implemented in both South Africa and Bangladesh. This provides health information for women via mobile phones, either through SMS messages or short message service, or through IVR, interactive voice response. These messages connect pregnant women, new mothers, and their families to gestational age-appropriate health information. Mama's goal is to reduce maternal and neonatal mortality through helping women, especially pregnant women and new mothers, and their families through the provision of enhanced health information. The idea is that this health information will help them to seek and receive improved preventative care. Reviews of Mama have shown that women indicated that the SMS messages have led to behavioral changes, including planning ahead for the delivery of their babies, extending exclusive breastfeeding, ensuring immunization, and so forth. It is widely argued that this is a successful mHealth innovation. Turning now to a second example, in Bihar, one of India's poorest states, the Ananya program uses mobile phones to support and train healthcare providers and to educate consumers, particularly women, in order to ensure better demand for and use of maternal, infant, and child health services. Through phone messages, community health workers can undertake short training courses and access short recorded messages which she can play to the families as she visits. Mothers receive a separate mobile phone service which is specific to the stage of pregnancy or young child and which reinforces community health workers' messages. A third component of Ananya emphasizes mass media and community-wide dissemination of information around topics like child pregnancy, inoculation, preparing for the birth of a child, and so forth. Like Mama, evaluations show that there has been a massive uptake of the program by community health workers and increased utilization of health services. My third example comes from Ghana. MoTech, or Mobile Technology for Community Health, was launched in Ghana in 2010. It aims to determine how to use mobile phones to improve prenatal and neonatal care in rural areas, and in so doing, to enhance health outcomes for mothers and newborn children. MoTech focuses on the dissemination of health information. Not everyone in rural Ghana owns their own mobile phone, and even in 2014, it was still common for phones to be shared by a family or in some cases by an entire community. Like Mama, MoTech provides mothers with free health information appropriate to their specific stage of pregnancy, either through SMS or IVR. An independent evaluation found that women in Ghana liked and remembered the messages and could cite instances where information had led to behavioral change for them. Using mobile phones to overcome the digital divide, as well as to address health and gender inequalities, has led to some staggering successes. Over 11,000 women enrolled in the first 2 years that MoTech operated in Ghana. India's Ananya program was used by over 210,000 community health workers in the first 7 months. Over 200,000 women have used South Africa's Mama service, and over 176,000 Bangladeshi women have called Mama in Bangladesh. The results speak for themselves. Yet, some challenges remain. In Ghana, there were challenges over accessing messages on shared phones. When women traveled and took phones with them, other women couldn't access those phones. In Bangladesh, Mama found that mothers in poor households did not have regular access to mobile phone services. They also found that pregnant women's access to mobile phones was constrained by their husbands, who held the subscriptions to the phone and who limited women's phone use. In order to deal with this, Mama registered a gatekeeper, or a second recipient of the service. Slightly more than 50% of women subscribers to Mama in Bangladesh have a registered gatekeeper. The need for gatekeepers was also found in Nigeria, where young women are encouraged not to actively seek information about topics like sexual health. These health topics cannot be discussed easily and should not be shared between genders, so women find it difficult to discuss health problems with male doctors. As young women are encouraged not to access this information and not to look for it, this results in men in their households and other gatekeepers like mothers-in-law relaying appropriate information to young women. The inclusion of a gatekeeper overcomes the immediate challenge of mobile phone access for health purposes, be it for young women in Nigeria or young mothers in Bangladesh. But it also reinforces women's gendered roles as mothers. It stereotypes women's activities as primarily domestic and child-related, and it perpetuates gender inequalities, as well as requiring women to have oversight from more senior household members. As Richards et al. Point out, this raises questions about short-term approaches which address maternal mortality, but overlook long-term strategies which might seek to address women's health through their empowerment. Jennings and Galliardo propose a similar distinction between transformative and non-transformative uses of mHealth. Transformative approaches pay attention to the incorporation of technology into people's lives and is shaping gender-power relations, whereas non-transformative approaches simply facilitate access to and use of phones for health dimensions. Overall, in a review of gender and mHealth, Jennings and Gagliardi argue that there have been positive transformations. These include men's greater participation in reproductive health decisions, particularly in Tanzania and the Democratic Republic of Congo, where men were able to access family planning information through interactive SMS portals rather than having to visit clinics. They also report increased autonomy in seeking and accessing health information and services for women, increased status and greater control over household resources when mHealth projects distributed mobile phones to women, and increased technical knowledge, skill and entrepreneurship for women when using phones to distribute and sell health-related services and products. Yet, Jennings and Gagliardi also report instances when mHealth has clearly not been transformative, when men insist that women hand over their project phones to them, when women require men's help to overcome technical and literacy barriers, and when interpersonal conflicts center on the use of the mobile phones, resulting in gender-based violence and/or in women abandoning their phones, and in some instances, in men's large-scale uptake of mHealth initiatives designed for women. In addition, some mHealth programs have reinforced men's patriarchal roles as heads of households and women's dependence on these men for approval, technical and financial support. After reviewing the available evidence on mHealth interventions and women's participation therein, Jennings and Gagliardi conclude that the rapidly growing literature on mHealth interventions provides little information on the extent to which such efforts have positively or negatively impacted on gender relations. Greater insights are needed into the ways in which women use mobile phones and how this usage is embedded within, while possibly also challenging, women's positions in society. As suggested earlier in this lecture, women, even in low and middle income countries, are enthusiastic about using mobile phones for seeking health information. Lambert and Louisel argue that health information seeking is increasingly being seen as a means of coping, a way of adjusting to ill health and relating to health promotional activities. Information helps people focus their attention and direct their efforts towards better health outcomes, to better understand the challenges they face, to assess available resources, to add meaning to health events, and to increase predictability and feelings of control over poor health situations. When thinking about how mobile phones facilitate access to health information, one has a powerful image of people downloading health information onto their phones and making appropriate healthcare decisions, and this is the image that we often see in the literature. For example, as Abertain et al. Argue, currently, the healthcare system in the low and middle income countries is witnessing a cultural shift from a traditional approach that relied on the patients following the doctor's orders without their involvement in decision-making to a more patient-centered approach where the patient is equipped with information and knowledge gained from easy access to modern technology. But this idea that people seamlessly move from one system of knowledge to another fails to examine how facts or information is translated into tacit or embedded knowledge that informs practice. This image is furthermore set in the context of developed economies, where people do have access to ICTs and use it to assess and sift information, and where social networks often play a secondary role to evidence and facts. Much of the understanding of health information seeking is based on high-income countries and on specific populations of people intimately involved in health issues who need information to control their condition, such as cancer sufferers and their carers. Health information seeking literature focuses on the needs of aging populations and on how individuals' personal characteristics shape health information seeking. Underlying much of this literature is the assumption that there is a formal health system with services which people can readily access and an easily available body of reliable, disinterested knowledge. Indeed, the literature on health information seeking supports the argument that access to information helps people to better navigate the health system and to access appropriate health care, improving their ability to act as agents within the system. As the following quote by Ansari and Al-Munawar suggest, accessing healthcare services through smart mobile devices, or mHealth, encourages patients to take more responsibility for their own health, such as to actively participate in decision-making about their health and help each other through information and knowledge sharing. Furthermore, mHealth provides patients with the ability to access and control information that fits with their personal needs. Presently, there is a lack of discussion on the kinds of knowledge that patients may already have, which may or may not conform to health information knowledge, and on whose knowledge counts. The approach we have discussed thus far assumes that emic, indigenous, and other personal information does not count in the same way as medical health information does. There is also little discussion on the roles of patients in relation to mHealth. Can patients take greater roles in health care and delivery arrangements through mHealth? Will having a larger role in healthcare ultimately empower patients, especially through the accessibility and control of information and knowledge using smartphone devices? Health information seeking in low and middle income countries may differ from that described in the literature for high income countries, because formal health systems are not always able to reach or provide for the entire population, because regulatory frameworks are weak and healthcare quality can be unreliable. There are far more constraints experienced by low and middle income countries' health systems, and mHealth, including both enhanced information and information seeking, cannot always overcome these constraints. As Noordam and colleagues show, in Zambia and Malawi, the key challenges to providing early infant diagnosis and nutrition surveillance are associated with human resources and health infrastructure requirements. mHealth interventions in these countries are effective in terms of overcoming barriers relating to communication and transportation infrastructure, but they don't address challenges like the critical shortage of skilled health workers. mHealth initiatives implemented without additional attention to health infrastructure can end up giving people information without providing the necessary services to complement that information, and can put extra pressure on already strapped services. Health systems in low and middle income countries are often highly pluralistic, with a range of autonomous actors providing services in an unregulated market and with far greater reliance on informal health care. This is explored in more detail in part 3 of this lecture. To end this lecture, I'd like to ask you, what do you think is the digital divide, and what types of barriers and challenges do people in low and middle income countries face when seeking to access health information electronically?